Good evening. I'm Augie Napoli, President and CEO of the United Way of Greater Cleveland, and welcome to the third session of our 2022 Community Conversation Series. The objective of these conversations is to provide a forum to raise awareness and increase engagement on important topics in our community. A series like this comes together with a great deal of help, and we have many organizations to thank. I would like to thank Rockwell Automation for supporting and making this series possible. Tonight's discussion is co-sponsored by the Adams Board. Thank you for your partnership in this important conversation. And thank you too to IdeaStream Public Media for being our lead media partner. And thank you to our community partners that you've just seen for their support throughout this series. Tonight's topic, the impact of the pandemic on mental health. We have a panel of local experts here to discuss COVID's effect on our community's mental health and substance use, as well as service delivery opportunities and barriers. We are privileged to have Marlene Harris-Taylor as our moderator. Marlene is the managing producer of the health team at IdeaStream Public Media. Marlene took over leadership of this team during the most significant health story of the decade, the coronavirus pandemic. She is also on the board of directors of the Association of Healthcare Journalists and Press Club of Cleveland. So without further ado, I'm honored to introduce tonight's conversation moderator, Marlene Harris-Taylor. Marlene?
Hi, Augie. Thank you so much for that introduction. And also, Augie, I have a couple people to thank, but I want to start by thanking you and United Way of Greater Cleveland for inviting me to moderate this discussion. I think I have to click a button here to get my video started. There we go. Can you see me now? Great. So, Augie, I also want to thank the City Club of Cleveland for hosting this series of events. We also want to thank, as you have, IdeaStream Public Media, the place where I work. We will also want to thank WOVU 95.9 FM, WOIO, and WKYC, who will be live streaming tonight's conversation. Now, we begin with questions that I have prepared for the panelists, and then you will have your chance to ask questions, or your questions will be asked, I should say, around 6:45 p.m. You can start texting your questions now, though. The number to text your questions is 216-307-5632. We will make every attempt to get all the questions answered. Again, you can text your questions to 216-307-5632. So joining me tonight for this conversation are Lavelle Custer. Lavelle is President and CEO of Murtis Taylor Health and Human Services System. Entering the health and human services sector in 1993, Lavelle has served in a variety of management and leadership positions. His expertise and experience covers the entire life cycle of how human services organizations design, deliver, manage programs and services. Lavelle, welcome to the program. We're happy to have you here tonight. Also with us tonight is Archie Green. Archie is a Cleveland native, hip hop artist, and advocate for mental health, having himself been diagnosed with clinical depression in 2014. His introspective single, Layers, which premiered at Vice.com in 2016, garnered over 25,000 streams in 2 weeks. The award-winning 36-year-old artist subsequently founded Peel Dem Layers Back, a 501(c) to promote mental health awareness through a hip-hop lens for Black men and boys. Archie, welcome to the program. Also here with us tonight is Scott Osecki. Scott is the Chief Executive Officer for the Alcohol, Drug Addiction, and Mental Health Adams Board of Cuyahoga County and was appointed on March 1st, 2018. He's been employed with the board in executive leadership capacities for nearly 3 decades. Prior to his selection as a CEO, Scott served as acting CEO and Chief of External Affairs. Welcome to the conversation, Scott. And Britton Paul is here. Britton is the Chief Operating Officer of Ravenwood Health in Geauga County. Britton is a graduate of Hiram College and Case Western Reserve University with a master's degree in social work. She's a licensed independent social worker with supervisory endorsement. She's worked in the behavioral health field for over 24 years, providing direct care, clinical supervision, and program development. Welcome, Britton. Tonight, Alicia Ellis will present the community questions. Ms. Ellis is the founder and creator of the multimedia platform Miles Luray. She's also the co-founder of the women's empowerment group Fierce Women on Board. So she's going to join us later to present those questions. So I'd like to welcome everybody as we get started with this conversation. And Scott, I'm going to come to you with the first question, if that's okay with you. So Scott, hospitals and mental health providers were already dealing with limited capacity before the pandemic, but these past few years, it seems, Scott, from everything I'm hearing, has pushed things to the breaking point.
Yeah, it really has, right? So when the pandemic came along and our providers had to social distance, they had to figure out new ways, right, to provide treatment. So something that the Adams Board and our providers advocated for and actually made a really quick turnaround was doing video telehealth.
Mm-hmm.
Yeah, telehealth, and that has really helped a lot of people. And in fact, at the providers and the Adams boards, we've also advocated to make that something permanent now. So even after the pandemic will go away, that is still an option for our clients. A lot of clients told us they really liked it. They didn't have to take a bus to get to services. They didn't have to get up and go somewhere for services. And it was still great to have contact, visual contact, or at least talking to somebody on the phone. It was great to see people, but also wanted to point out that even during the pandemic, every one of our providers, they were still open. So there are some people that come, that need medication assisted treatment, or they need to receive medicine or be seen by a psychiatrist. So those appointments were actually still happening in person. So we really have to thank our providers for really keeping the system open. But like you said, though, I mean, it was just we are suffering right now with a workforce issue. All of our providers are in need of the workforce, right? And this didn't only affect other industries, but it also affected behavioral health. And so there may be longer wait times now. And also another thing with the pandemic, though, like you were saying, is actually that people started to realize more about mental health or addiction issues because it started to impact and affect more people, right? People were dealing with isolation, people dealing with grief. They may have lost a loved one. And remember how people were passing away. They wouldn't be able to even go see the person, right?
Right.
So that created a lot of grief. And our providers really have stepped up to the plate, though, to help provide those services to people, to help meet those needs. And
it has been difficult, though, right? So I want to just move over and chat with Britton for a minute, because Britton, I know that as Scott said, you all are dealing with lack of staff. Like, we've heard so much in our society about, the Great Resignation, and that every employer is having a difficult time finding workers. Well, that's true in the mental health sector as well, right?
It definitely is. I actually looked back to see, just in particular with Ravenwood, since January even, and again, this is, just been that short period of time, we've had 14 different therapist positions opened, and we've only actually had 6 therapists apply. So when we're talking about the shortage, I mean, there's a shortage. We get a lot of our therapists because we have internship programs. That's really how we're moving them along. But the concern is even the therapists that we have, and I guess I want to broaden that to even just the whole behavioral health field.
Mm-hmm.
People are tired. They're stressed. What I find really is, we have, what you call secondary traumatic stress from workers, right? The more you hear about trauma, it does affect you. Then they themselves are involved in their own living through the pandemic, right, with their families. And then on top of that, you have the shortage of the workforce. So they're working longer hours, later hours. They're not wanting to take vacation because they feel bad. They're exhausted. So it is hard to keep staff. It's hard to really help them take care of themselves. And it's just been an issue.
So after a while, it sounds like they just burn out. The people who try to stay, sounds like they burn out. I want to see if Lavelle's having the same issue. And I know, Lavelle, we chatted earlier. You told me it's the same thing in your agency, just very difficult to find people.
And if we take a step back, even before the pandemic, this field, the mental health substance use disorder treatment field, has always had a very tight labor pool. There's always been a shortage. There's always there's been a historical need to encourage more individuals to take up the career, and the pandemic just exacerbated it. We are finding that the entire labor market has really gone into, and our field, but other fields, in particular other health fields, that has gone into a self-care mode and a self-protection mode, sort of a group trauma that individuals are really stepping back from the field. We are finding that individuals are leaving the field, leaving our organization, and are actually changing professions altogether. So not only do we, that we start with a situation where not insufficient numbers were going into the field and shortages existed, but now we have a situation where individuals are actually leaving the field. We employed, prior to the pandemic, well over 250 staff, and since the pandemic, we're under 200 staff, and this is across the board. So I'm not just talking about trained mental health professionals, but finance, building services, just across the board, professionals who are needed to operate a human service organization, and it's extremely challenging. And I think it goes back, as Britton said, it goes back to trauma, and we are, seeing a workforce, a society in trauma due to COVID, or exacerbated by COVID.
Lavelle, would you call it a crisis? Would you label it a crisis?
Absolutely. A pandemic and crisis go hand in hand, and it's hard to have a worldwide health crisis and it not affect various industries, and particularly the caring industries and the health industries that are, in the position or required to actually respond to this crisis. So we are definitely in a crisis, and the crisis isn't over. I think, Marlene, when we spoke earlier, that was a question you posed there. Is it over with? No, it's not over with. And we hear about post-COVID, from a personal health perspective, but there's post-COVID when it comes to organizations as well, and the life cycle of organizations, and the way we deliver services and the way we operate. I'm going to get a little bit into the operational business aspect of things, but the way, what's needed to maintain the viability of an organization to provide these services to a community, that is all now shifted. The business models have shifted. If you don't have people, you can't deliver the services, you can't generate the revenues to keep the organizations running. And when we look at moving to modalities such as telehealth versus in-person modalities, the model changes as well, because fewer services are delivered at the same moment, at the same day. It's hard to sort of co-locate, or you've been built out to co-locate services, and these co-location business models no longer viable, and organizations are constantly, we're in the middle of flux, trying to figure out how do we meet the needs of the community with respect to what we're seeing in terms of health and healthcare.
Well, let's talk about it from the perspective of people who are trying to get care. And Archie, I want to bring you into the conversation because you've been there. You've been in a situation where you needed care. Can you imagine what it's like, Archie, for folks who need care? They're in a crisis, or maybe they're not in a crisis, but they can't get in at any of the agencies because of staffing?
Yes, I can speak from my own personal experience, lived experience. I mean, even before the pandemic, years before the pandemic, there was a period of time where, I was uninsured, and I went to, the free clinic, Mayo Clinic, and, I was paired with someone who didn't have the competency to see a Black male as a client. So there's, on top of the pandemic and this overwhelming need for support, there was also lack of cultural competency with certain agencies as well. But just recently, I had referred a friend of mine to the practice that I see for my own therapy, and they are so inundated that he still has not been able to place a first consultation. So across the board,
How long has he been waiting, Archie? Do you know?
at least about a month, maybe 2-3 weeks. But it's very difficult to be in need for something so critical, especially at times like these, and to just not have enough help, not have enough hands, that are here. And I mean, and I also would be remiss if I didn't acknowledge the fact that there are also not enough men and Black men in the field of mental health and wellness as well, which is why it's so important, for me, in terms of, kind of putting myself out there as an advocate to help attract more Black men and men, period, in this kind of work.
Well, I can imagine that the situation is only worse in terms of trying to find Black men who are culturally competent. Now, let me just give the number again, though, so because I know that there are people out there who probably have questions for you guys already. So I want them to get their questions ready, get their questions get ready to text those questions into us. The number is 216-307-5632, 216-307-5632. If you have questions for anyone on the panel, or if you have just a general question that you'd like everyone on the panel to address. Scott, I'd like to come back to you and talk about this idea. You mentioned that, telehealth helped,
Yes.
Was sort of a release valve, if you will, to help with some
Yes.
of the increased demand. But what Archie is saying that his friend encountered, we're seeing that across the board, aren't we? The longer wait times for people.
Yes, we definitely are. And, I wanted to respond a little bit to Lavelle and also to Archie. So with the workforce challenges, the Adams Board, we're taking this very seriously. We got together a group of our providers to come together to be a work team, a workforce, to try to figure out how we could address some of this. There was a definite real crisis in the children's agencies, residential children's serving agencies, that they wouldn't even be able to accept kids because they didn't have enough, they didn't have enough staff. So what we did is we provided about $1.7 million to a couple of our children's agencies so they could boost the pay to keep the individuals that they did have, to offer incentives to attract new people. So they're still using that money now and still trying to figure out, to find people to work in the system.
Well, Scott, can I ask, did that work? The extra money, did that work?
It's working a little bit, not as fast as we kind of would have liked. And then it's sort of just a kind of a one-time stopgap too, because then, like Lavelle was saying, you got to have people there to serve in order to generate the revenue to keep the people as well. So it's sort of working, but they were telling us too, because with the stress of the job, sometimes people would just walk off the job, or they would leave because it's so stressful. They would just get hired, and then it wasn't kind of what they learned in school. So another part of that is that we helped to place some students into positions in our agencies in the behavioral health workforce for their internships. And we're looking at ways possibly that we could offer stipends for those internships as well. And another thing that we did to try to put people in the pipeline to be interested in the behavioral health system, we developed a video series along with the Cleveland School District. And it's for grade school students, high school students, and then people going into college, about telling why they're in the business and what they get out of it, and how it's really a rewarding career. So we're trying that too. We're trying to work that out. That's not an immediate relief of that. Another thing with Archie, he was talking about the cultural competency. So the Adams Board, we just started a diversity, equity, inclusion initiative. And we have a community work group that's together that's working on that. We hired a consulting service, Redcon it's called, and they're developing for us a 3-year DEI strategic plan. And then part of that is also looking at attracting diverse people into the behavioral health system. And then like Archie is saying too, people want to be treated by the people that look like them, right? People want to be able to relate to the individuals who are helping them.
Absolutely, that's definitely helpful. Yeah.
Yeah, so we're doing that. And then the first time last year in our request for proposals for agencies, we asked about their cultural makeup. We asked if they had a DEI policy, and that's kind of going into our decision making now as we're trying to make our behavioral health system as diverse and culturally competent as possible.
Well, let me ask Archie to respond to that. Archie, what do you think about that? That there's movement happening, there's a DEI plan being put together. What do you think about that?
I mean, I think it's definitely a step in the right direction. I think, like Scott mentioned, it is working. It is a process. So I also, I work part-time at NAMI Greater Cleveland as well. We went through a DEI initiative. It's actually going on across all of NAMI affiliates across the country. But this is something that is somewhat new and will take time to build. But I think that, this type of intentional work is definitely a step in the right direction.
What do you think, Lavelle?
I agree. And Archie, as you mentioned, the need to see individuals, or the need to be seen quickly and not, have an elongated wait. And one of the things that we have found that is extremely helpful is peer professionals, individuals with lived experience in the community. And while it's not treatment per se, it does represent regular check-ins, regular empathetic discussions that allow individuals to seek help and find help, and to be heard, and to recognize that there are others going through what they're going through. And peer professionals have been one of the areas that we have found to be it's something that even when done as an organization, that you say, for instance, you're not billing for the activity, but building these peer professional networks, these structures, supporting the peers and supporting consumers who are struggling, and allowing them to support others.
Can you explain a little bit more what that is, Lavelle? I mean, I have a sense of what you mean, but I want to make sure that I completely understand. What do you mean by peer professional?
So we're talking about an individual with a life experience, and that life experience could be with mental illness, it could be with substance use disorder, it could be a variety of illnesses, and an individual who is in recovery, who has improved to the point that they are in a position to share their lessons learned and the things that has helped them with others who find themselves in that same position. There is actually a peer recovery supporter specialist position. There are, with the state of Ohio, there's a set of standards. It's a structured profession, if you will, that individuals can pursue, and without having a degree. And really, it's a life degree. Is
it pretty much for people with substance use disorder?
No, there are
peer professionals,
mental illness, mental health peer supporters, professionals as well. You can be a peer supporter in oncology. I mean, it's not illness specific. It is an individual who, now in our field, in the behavioral health field, it's typically mental illness and substance use disorder. But you have peer supporters. As a matter of fact, I don't believe it started in our industry. Peer supporters in all areas of health that really have gone through, an education, a university of life experience that, and oftentimes, I mean, what we see on our evaluations, what we see on some of our outcomes is the improvements, the changes from peer support work. rivals, if not, exceeds that what we see with a trained professional counselor. So it's different, but it's extremely important in its own.
It looked like Archie wanted to jump in there. Did you want to jump in, Archie? Looked like I saw
Yes,
you want to jump
looks like you read my mind.
in.
The type of work that Lavelle is speaking of is basically the work that I do. I am not licensed. I do have a certification in mental health first aid, which was provided by NAMI, Greater Cleveland, and the Adams Board. But at the same time, the work that I do is based on my lived experience, living with depression, living with anxiety, living with PTSD, and offering that type of support and empathy to other individuals who are going through the same scenarios. And I've also done a little bit of work in life coaching as well. And I think, again, like Lavelle said, although, this type of work is not work of someone that is licensed per se in the clinical field, we're licensed in lived experience. We speak from the heart, we speak from experiences that we've had, and we offer any type of, pearls of wisdom based on, what has helped us, various coping mechanisms, reemphasizing the fact that you are not alone. You're not the only person that's experiencing these symptoms, and you won't be the last. And so those are just speaking from authority, and really anyone can do that. Anyone that lives with a mental illness can literally, that's part of what we do at Pilgrim Lairs back, with this Cope Dealer initiative that we did this past year, is to create a community of individuals that know how to cope and can recognize not only mental illness within themselves, but their community members as well.
That's fantastic. I want to go back to Britton and ask Britton, do you have children that come to your agency for help and assistance? Because we're hearing so much about how children have suffered during the pandemic with mental health issues.
Yeah, we treat children and adolescents, adults, everyone, across the lifespan. We've seen an increase in school-age kids coming for services. I know the CDC just put out something that said really that high school students are what, 33% of them say that they have anxiety and depression, and actually 20% of them say that they've had thoughts of suicide. So, really, they're struggling. So our referrals keep coming in. It's a huge increase. Just to add though to the peer supporter, conversation, we have, definitely included the peer supporters in a lot of the work that we do. I think peer supporters are also, from what I have seen, they keep them connected to therapy. The peer supporters really are the ones who keep the clients connected to, the therapist that they have a connection with, even if they, maybe they struggle and they don't come to a couple sessions. It's the peer supporters, I think, that really then pull them back in and keep them engaged. We have added peer support actually also to some of our residential programs. And so, that is also key. And I just think having that middle layer of someone with lived experience to be able to talk to the youth, to be able to talk with the adults that are having some of these issues, I think it's one of the best things that's happened to mental health in a long time.
I'd imagine that works really well with teenagers too.
Yes.
Having someone who's a peer, because teenagers, they don't listen to anybody over 30 anyway, right?
Well, and these peers are older. So these peers are older, but they're not seen as, a professional as far as a therapist per se. So, and what's nice is the peer supports, they talk about their experience. We're therapists, we're it's not about us, right? So we're not divulging all of our personal stuff. We're really, the peer supporters are, they're connected in that way, and it's very powerful for them.
That's fantastic. Well, Scott, I want to switch gears a little bit and talk about the substance use disorder over the pandemic, because that's another area that we've heard just exploded. I can remember in the early days when everybody was on lockdown and then it opened up. I remember doing a story and I was told, when people were on lockdown, they kind of stayed home. And then when folks started coming out, they started using again, maybe at the same level they were before.
Yeah.
and they hadn't built up that tolerance back up. But we are well beyond those days. So
Mhm.
I wonder if you can share with us, like, what's happening now?
Yeah. So, unfortunately, right, overdose deaths were over 700 in 2021, and we're on par again to do that in 2022. So people are, they're looking to self-medicate, right? We're talking about stress, we're talking about anxiety. People, let's say they even weren't using before, that they're starting to use because they're looking to self-medicate. We're talking about the students, right? Like down at Ohio University, right? Recently, and what happened there was they thought they
Is
were
that Ohio University or is that Ohio State?
I'm sorry, Ohio State. I'm sorry, I always get those two mixed up. My daughter went to Ohio University. But they were there, right? Probably what happened was they were looking to take something to help them with their anxiety and help them study, right? But unfortunately, the way that things are now in our world, that fentanyl is in a lot of different things. It's in pressed pills. So they thought they were taking something that looked like a pharmaceutical. In fact, it was fentanyl. And then they end up overdosing with that. And some of them died with that. So fentanyl is in cocaine, it's in methamphetamine. The drug cartels are putting it in everything now. They're putting it in because it's cheap. They can cut the drugs, right? And they also want to get people hooked on something else that they're not even think that they're taking. So they're looking for new customers as well. So we really want to get the word out to let people know. In fact, at the Adams board, we don't condone drug use at all, right? But what we do is we want people to know what they're taking. We want people to survive. We want people to be able to get treatment, to get to that point where they want treatment. We hand out fentanyl test strips. We have those out in the community so people could test the drug that they have to make sure that it doesn't have fentanyl in it. And then we also have 100 Nalox boxes located throughout the community, at laundromats, at corner stores. We even have some at the Rock Hall of Fame. So just in case anybody does overdose, that people are there, you could save them, right? Because we want to save lives. We want people to live. So, but with all of this going on with the pandemic, right? And like you said, that people too, they stayed home, right? They were taking care of, remember everybody was looking for toilet paper. They were looking for that. So they weren't that. So, but when they went back, they went back to using at the same level they were before, which is deadly. Right. So we're also finding that our crisis hotline number 623-6888, right? And also I want to point this out, like to Archie's friend, right? They could call that number to try to get maybe a quicker referral, or they could get some advice to help during that time.
Maybe you should give that number again, Scott.
Yep, it's 216-623-6888. It's 24 hours a day, 7 days a week. And also, I wanted to mention our diversion center, right? So with Cuyahoga County, we partnered and we opened a diversion center last May. So we've been open for about a year now. Originally started out with just police referrals, but now it's open to the community. A person can make a referral to themselves or a friend. Now it's strictly voluntary, right? But let's say a person is in a crisis situation, they would be able to be taken to the diversion center. They could be stabilized. They could have detox services right away at the diversion center. And the way that you get into the diversion center is by calling that 623-688 number. They'll do a brief survey or whatever with them. I'm sorry, I can't remember the exact word. But then when they go there, they'll get their total. They will look at them total and to make the decision of what level of care that they need.
So Scott, that's great. So if you're a family member and you have a family member who really needs help, now there's something that you can do no matter what time of the day or night, right?
Correct. Yeah, and it's 18 and up. It's only for adults, 18 and up. And once again, it has to be voluntary. So the individual has to want to go there.
Okay.
So originally it was diversion from incarceration, but it's actually diversion from further crisis, right? That's what we're doing there. And that's operated by Oriana House. But the only way that you could get admission into the diversion center is by calling that 623-688 number. So I just kind of wanted to point that out for people who are in true crisis. There is some quick services available, even suicide prevention, you call that number, right? And we have mobile crisis team that might come out to the individual depending on the situation. If police officers are called to that situation, they could call that number as well and make referrals to treatment.
So, Scott, do we think that most people that the overdoses are accidental because of the fentanyl? Do we think, is that what we're hearing is going on?
Yes, yes, and Lavelle could jump in on this too, I'm sure. But yeah, people just
Yeah, I
don't
see
know.
Britton shaking her head. Britton is nodding too.
Right? It's so dangerous. The fentanyl is so dangerous. And I can't remember the name of it, but maybe the other panelists do, but there's another new synthetic out there now also that we have to worry about. So it's constantly changing and constantly evolving. And that's what we want people to know, right? Know what you're taking, right? We want you to make an informed decision on that. We want you to live. We want you to get into treatment. And even though it may take a little longer to get into treatment, but one way might be in through the diversion center, maybe to a little quicker treatment.
Mm-hmm. So, Britton, you were shaking your head. Did you want to comment on that?
We've just seen our groups, our IOP groups, our addiction.
What's an IOP group? What is that, IOP group?
It's 3 days a week, intensive outpatient treatment for those that have an addiction diagnosis. So it's an intensive treatment program. They've doubled, like even all throughout the we've had, whether they were run virtually or in person, our groups have just exploded. People have, kind of come in, they do want help. Again, we're just seeing in such an increased number of people calling, getting intakes. Unfortunately, sometimes, there's a little bit of a gap as far as, when they call. Sometimes, they're coming in for an assessment and maybe that assessment takes a little longer. Again, we have to kind of weigh the trying to get them in to see a therapist and make sure we're not overloading our therapists. But sometimes a fast track is to get them into groups, which I'm sure a lot of the other programs here are doing. But yeah, I know for us, it's exploding.
And Britton, we've also heard that there's over this past couple years, there's been an explosion in suicides as well.
We have. I know. Again, I think my concern, I'll talk about this more in the sense of, the adolescents, because, working a lot in the schools in Geauga County, it's just really concerning how many kids are talking about that they even have thoughts of suicide, and making sure that, they have the resources and that they can talk about it and they can get help. The upside, and I'm not quite sure how much, and again, I'll be curious of what, the other panelists have to say. There is a little bit of wondering if some teens are coming into treatment saying it's because of COVID. And so that's giving them a reason to come in for treatment, sort of hey, I can come in and not say I'm anxious or not say I'm depressed, but it gives them sort of a reason to be connected. Because again, we've seen such an increase in those referrals as well, which is good. But again, ultimately, what we're seeing is just the increase in anxiety and depression.
Overall.
Marlene, I have some stats, just real quick. So during February to March of 2021, suspected suicide attempts, ED visits, emergency room departments, were 50.6% higher among girls ages 12 to 17 years during the same period in 2019. And then among boys aged 12 to 17, suspected suicide attempts with emergency room visits increased 3.75%. So we're definitely seeing an increase in suicidal attempts, but it's also good, right, that they're getting to the emergency departments.
Yeah, that's good.
They're getting the help, right? And so
but it's hitting the girls. The boys are suffering too, but it seems to be hitting the girls harder.
Yes, yeah. And then mental health related emergency room visits in adolescents 12 to 17, just mental health, increased by 31% compared to 2019, from 20 to 2019. So definitely the pandemic has definitely had, an increase on that. And the Adams Board, if anybody wants, we offer QPR training, question, persuade, refer, and we go out to the community to give that training. And it's a training that anybody could have. And it's okay to ask someone if they're thinking of hurting themselves or suicide. You ask, that's the question. The refer, to say, I want to make a QPR, persuade, please don't do anything until we can get you help, right? And then that's
so hard, Scott. People feel like they're not sure. Should I ask?
Right. People,
Right.
people are afraid, right? It's uncomfortable, but research and everything have shown you need to ask the person, are you thinking of doing this? And then please just wait, don't do anything yet. Let's get some help for this. So that's the whole persuade and refer part. And then when RJ was talking about peers too, excellent way of getting people into treatment or staying into treatment. We have several programs. We even have peers in emergency roomes. And when a person overdoses or a mental health issue, they could go and talk, and the peer will be right there in the emergency room and say, look, let's get some help. I did this, you could do this too. So that's really important as well. And just want to mention, we have St. Vincent Charity a psychiatric emergency department as well. So that's also another resource for our community when people are in a definite crisis like that.
In crisis. Archie,
And
did you have
Marlene,
a thought on this? Yeah, go right ahead.
I did want to comment. I actually went through the QPR training that Scott mentioned. It is highly effective. Speaking from experience, I've spoken to a child as young as 6 years old about suicidal ideation, from bullying and things of that nature. And, of course, it's shocking. It's hard to talk about, but, at the same time, through the training, learning how to speak from an objective point of view, as opposed to thinking about the fact that, oh, this person is this young, and thinking about, we have to consider, we're in the 21st century, it's 2022. These kids are, the main thing I've been saying is these pandemic babies are different. They come out with so much character, and so these kids have a lot more access to information. And
They do.
So in the past, like when we was kids, we didn't really think about like taking our own lives because we didn't know how. It wasn't something that but now it's everywhere. Information is everywhere. And the other thing I wanted to just briefly comment on is, through my work at NAMI, I also stop by the Diversion Center on Tuesdays to speak to clients that are there. And I can say, from firsthand experience, the Diversion Center is a godsend for this epidemic of people dealing with addiction, mental illness, homelessness. I'm grateful that space is here in our city and serving a great need for so many as well.
So, Lavelle, I'm wondering, do you have any thoughts on this increase in suicides in our community and in the country, in terms of what are you seeing on the ground and hearing from people?
We are seeing quite a bit in terms of increases in attempts of suicide. And, earlier on in the conversation, I referenced the concept of post-COVID, and I think we, need to sort of keep in mind that, again, this isn't over. And a lot of what we're seeing is behaviors related to coping with where people are right now. And opioid use, yes, but we're also seeing an increase in alcohol, marijuana, and a significant increase in food. So food, overeating and just using food as a mechanism to cope. And while individuals at this point may not, be at the point of addiction, may not be at the point where it is totally disrupting their lives, the process is starting, and that cumulative process over time of relying on alcohol to cope, relying on marijuana to cope, will have these post impacts as we move forward. And what we're going to see as a society, what we're going to see as a community here in Cuyahoga over the next few years, I think it's going to be unprecedented. It's going to be a true COVID crisis, post-COVID crisis.
Lavelle, thanks for that reminder that it's not over. Like, so many people want to move on and say, COVID's over, it's time for us to move on, but it's not over. But it is time for us to move to hearing some of the questions that maybe were texted in. Alicia, you want me to give the number one more time? So the number is 216-307-5632. 216-307-5632. If you have a question for any of the panelists, or if you want the entire panel to address something that you might be thinking about. Alicia, I'll turn it over to you.
Also, we have some great questions coming our way. Great conversation thus far. One of our questions is, what accounts for more girls committing or attempting suicide than boys?
Who wants to take that? Scott, you think you want to take that one or get started on that one?
Look, get started on it, right? So, how could I say this, right? Girls, right? They're more self-conscious, I think, about the way maybe that they look. I think girls also could be mean with bullying in schools, to say that nicely, more than boys.
They made a whole movie about that, Scott.
Yeah, Mean Girls, right? One of the best movies ever. But yeah, right, and boys may also take out their I want to say their anxiety a little bit different than girls, right? Or they maybe be more physical in their reactions back and maybe not hold it in as much. But that was just my opinion. But I don't know, maybe Britton or Lavelle, no, they are.
I don't know that I have an exact of why, but I definitely know statistics out there say that girls and women are more likely to attempt than men. Now the reverse of that,
Yeah.
Men are more likely to complete. So
That's true. Yes.
And that's because of guns, right?
Exactly. Yes.
Because men tend to, seek out guns more than women.
Mm-hmm. And the Adams Board, along with the Ohio Suicide Prevention Alliance, there's a new campaign out now about guns, and it's also with gun advocates and with Fin, Feather, and Fur, that organization as well, that about keeping your guns locked up. Right. So if an individual in that moment that they're thinking of suicide, if they can't get to a gun, that it can help reduce, those suicide, those completed suicides. Also, just thinking too that, with girls, maybe social media and comparing themselves to others and fear of failure as well. And what Archie, right, when we were young or whatever, we didn't have all that out, right? Maybe you got bullied in school, then you went home, but now this is just 24 hours that kids are having that. And then also, I got a text from our PR person, and she wanted to me to let you know that in the last 3 years in Cuyahoga County, there were 526 suicides within the last 3 years. And now we're looking at the rates now. It's that the ages are more 20s and 30s now. Before, men used to be like 50 and older, but now it's the ages are getting younger.
Wow. Well, we appreciate Beth making sure you had that stat. Did anybody else have a thought on that question? Anybody else on the panel?
I was just going to chime in. And again, I primarily work with Black men and boys, but one of the standards in terms of how men act out is we take it out on our loved ones. So there's spousal abuse, whether verbal, physical, and that can lead to a spouse in that situation or a child in that situation to either create a plan or act out on that plan. And the other thing that can't be overstated or overstepped rather is the fact that there's a prevalence amongst African American youth as well, both boys and girls, that has gone up, that is really not covered by data or stats historically, just because when it comes to specifically speaking from the Black community, and admitting that we have depression, admitting that we have anxiety, there's still a very prevalent stigma. And so because of that, when we're asked, statistically speaking, if some of these young, children are asked, have you ever thought about suicide? They'll say no. Whereas in a lot of cases, they just act out. They don't have a plan. They just do it because of the way that society is set up and how there's systematic oppression and racism and all of these different things. And that's the other thing, when we talk about social media, we look at all of the violence, all of the brutality, the situation that just occurred in Buffalo. We're inundated with all of this negativity, this toxicity. And because of that, we internalize that. I mean, we saw what happened with George Floyd, with Breonna Taylor, because we were at home and all watching, there was a different major macro response where this has been happening for like decades, centuries even. So to see that kind of response is, I feel like that's part of the root as well, because a lot of times we're siloed at home, speaking as far as youth, young men and women, part of what led to this uptick in depression, anxiety, and suicide attempts is the fact that they're at home. They don't have any interactions with any other human beings. A lot of students, especially 2020 and 21, may not have gone to prom, may not have had a traditional graduation, and that can really impact someone mentally as well.
Yeah, missing all those milestones in your life. Yeah.
Yes.
Do we have another question?
Yes, this actually is directed to Archie, which I think pairs with what you're speaking about now. How did you develop the courage to talk about mental health issues so openly? And when there's such a stigma like you're referring to about mental health, especially in the brown and Black community?
Great question. And to answer that, I can answer that in a couple different ways. Part of it was my art. As a hip hop artist, I channeled my story, my pain, my struggle into a song, not really, trying to really save anyone but myself. I just wanted to express myself. And the response, the viral response, 25,000 streams really was like, a red light for me, that this is a critical issue, that this is something that really needs to be discussed. I can also say, my mother's a 20+ year breast cancer survivor, and she didn't hide, what she was going through. She's become a champion for breast cancer survivors and breast cancer research. So I feel like I get some of, my strength and courage from that. And then lastly, I would say, the importance of knowing that what I went through, what I continue to go through, because I still live with depression and anxiety, is not, it's not abnormal. It's about as common as the cold. And I know the power of telling my story to anyone else who may be living through the same situation. Like, I wish I had someone that looked like me to have told me. That's what got me into therapy. Another Black male psychologist had asked me, have you ever gone to therapy? If that hadn't happened, I might not even be here today, to be honest. And so any platform that I'm given to share my story, I will do that. And the last thing I'll say to this question is changing the perception that I had on my story. For the longest time, people have told me, oh, you're brave, you're courageous for being so open and transparent about your story. But I never really saw that, because every time I told my story, I would relive that trauma, and it would trigger me at times. And it wasn't until recently that I realized that my story is not a story of trauma, it's a story of triumph. It's not a story of struggle, it's a story of self-care. And it's also a story of self-love. I loved myself enough, in spite of everything I went through, that I decided to keep going. And that's one thing I want to, share with anyone that's watching, that's going through a tough time, is know that if you're still here, it's because you love yourself enough to keep going. So keep going.
Wonderful, wonderful testimonial, Archie. Thank you for sharing that.
Yes, thank you. Thank you for sharing. Another question we have here is, how do individuals without insurance access mental health and substance use resources?
Maybe you could take that, Scott.
Yes, so the Adams Board is a payer for services for people who don't have insurance. So if a person doesn't have insurance, then they could go into any one of our providers or call that 623-688 number for a referral. And then when you're there, the workers there will help you get onto Medicaid if you don't have insurance. But in the meantime, though, your services would be paid for by the Adams Board.
So it was specifically about if you don't have insurance?
Yes.
Question? Okay.
Oh, sorry. Yeah.
Yeah. Okay.
All right, another question. We got them coming in hot here. So in the absence of enough behavioral care providers to meet the demand, are there efforts to create more group therapy / support group opportunities for folks?
I think Britton has addressed that a little. Lavelle, would you like to address that?
Absolutely. Our organization and all of our contemporary organizations, mental health and substance use disorder treatment providers, are adapting to what we see in terms of community need and changing, the frequency of groups, changing the availability of groups. You know, from a treatment perspective, the number of people that you can have in a group in order to be effective, there's a cap. You just can't continue to add people to a group, but you can work at that optimum level, and you can offer those groups at times and make them accessible on days when individuals who, you know, because of life circumstances, maybe they're caregiving, maybe they're working, can't come in 9 to 5, and it's critical to make those services available. And we're all making those shifts and changes to make those group services, as well as the individual services. And oftentimes there are opportunities to pair the individual services with the group services. So in other words, you may have a group service going on, you know, from 6 p.m. to 8 p.m. at night, and you know, you can have an individualized session that happens at 5 o'clock. That whole concept of trying to co-locate, trying to put primary care with the behavioral health care in the same physical location, and making services available to address whatever needs that individual has, so that, you know, maybe they're coming in for a medication injection, and at the same time or immediately after, they go into an intensive outpatient substance use disorder treatment group, or some type of a mental health educational group. But, you know, we're all being as creative as possible with the resources that we have. And, you know, as Scott mentioned, you know, the Adams Board is hard at work making resources available and really supporting us with, you know, options to deliver these services and make them accessible on days and at times that people need to see them.
You know, I hadn't thought about that, Lavelle, that people needed at night, on the weekend, you know, different times than the 9 to 5. Britton, did you want to add to that at all?
You know, my experience in Geauga County, again, I know it's a little bit different, but we've offered a lot of different opportunities to have some support groups, even some virtual groups. I have found that when people think that they're in a group temporarily before, like, you know, there's a group that becomes open, they don't really want that. They want to kind of wait for the group that they're going to be in. So we have tried to figure out how to offer some education groups, or, you know, we also have emergency services. We have crisis workers who will then touch base with them periodically. But our experience really has been is people don't want to have to talk to a bunch of different people. They want to get to the provider that they're going to see. And so it's a little tricky.
Yeah, that makes sense. I could see that. Yeah.
Is it
So do we have
possible-
another?
Can I
I'm sorry.
chime in
I'm
real
sorry.
quick?
Go ahead, Archie.
I just wanted to mention, you know, one of the things that we're doing at NAMI Greater Cleveland, which is really, we're the first out of all of the affiliates across the country to do this, is we started a group called Lean on Me Collective Support Group, specifically for African Americans living with mental illness. And I was very intentional with setting the time at 7 p.m., you know, to start, because as is, you know, standard, you know, it's a little bit harder in the Black community to get in a support group in the middle of the day. And so it was very important to us to not only set up a group that was culturally competent, but to account for the time in the way that Lavelle was speaking, specifically for, you know, this demographic. I mean, you can learn more about that support group at namigreatercleveland.org. But I wanted to make sure that I shared that information. It's something, you know, as far as what Scott said, we're trying to get creative in our approach.
Yeah, thanks for getting that out there.
So that people could go to our website. We have all of our providers listed there, and you could do a search on the services that you're looking for. And for, like, if you need like grief support groups, we have Cornerstone of Hope that we support. Then we support some of NAMI's family groups. And then also there's some other ones. I can't remember all the names off the top of our head, but we had some new ones that we added this year.
Beth will probably send you a text on that.
Yeah.
Another question here. What are some signs of drug use in adolescents? Two-part question. And how can parents get them treatment?
Yeah, good question. Who wants to take that one?
You know, going back to what Archie was saying, oftentimes it's simply a matter of asking the question. And in our screenings and when we connect, whether it's with a peer support situation or a therapist or a case manager, within those conversations, the question is asked. I mean, obviously there are signs, in terms of eyes and physiological signs, but in many cases, simply asking the question about, drug use and have you tried drugs, and being open with the children in your family, the children who are close to you, and if you are a professional, the children that you work with professionally, I think is probably the first step with respect to addressing the issue. And changes in mood, changes in behavior. I mean, there are protocols that you can look up on the web that'll kind of take you through and give you a sense of it. But it is really a change in sleep patterns, a change in normal routines, a sense of stress, a variety of things that you would view as being different from the normal developmental course that you would see with that child.
When they start acting different. And what were some of those? You said there were obvious physical things to look for. What are those?
Sweating, red eyes, changes in weight gain or weight loss. There are a variety of things physiological that if you might think the person had any illness, and we have to think of SUD and mental health treatment as any illness. And as we see changes in physiological in a person's physiology, we need to ask those questions that will lead us to what is the root cause, what is the illness here.
Well, I have 2 children who are basically grown now. And when I asked, it was no, Mom.
Well, Marlene, oftentimes it's who asks. So and sometimes the response from to Mom's question would be different than the response from a peer or a professional or even a teacher. So we all have to be involved in those children's lives.
Everybody they may not want to tell Mom or Dad.
Yeah. And even when it comes to a spouse, a husband asking the wife and the wife asking the husband, that you may get a different response, or maybe not as truthful a response, because of the power relationships, whether it's the power of the parent to the child or the power between spouses.
I just want to add too that the Adams Board, we're promoting a SAMHSA campaign that just came out, and it's called Talk and They Will Listen. And if people go to our website, adamhscc.org, and you could find all the information on there. There's videos on there, there's tips and things like that to talk to your kids about it. So
I probably should have looked up those tips first, huh?
We're just launching this, so you'll see billboards and bus placards and all sorts of things out there.
No, my kids are doing great. They didn't have any issues there, but that's good stuff to know, though.
Yeah.
Our next question is directed to Britt, and the Ravenwood Health is one of the new care management entities for the new Medicaid Ohio RISE program. Can you talk about your role and how you think this might help address youth mental health needs?
Sure. So Ravenwood Health, we through Ohio RISE, we are designated as one of the 20 in the state of Ohio who became one of the CMEs. I want to add that it's Ravenwood Health in partnership with Crossroads, New Directions, and Community Counseling, because we got that catchment area as far as Jaga, Lake, Ashtabula, and a real small portion of Cuyahoga. The basis of it is that you'll have a care coordinator assigned to a child who has either intensive care coordination needs or moderate care coordination needs. And that care coordinator is just there to help the family have a voice and choice, really help the family learn how to navigate the system. I mean, let's just face it, our system sometimes is difficult to navigate. And it's there to make sure that the services being provided to that kid makes sense, to that family makes sense. And the care coordinators will pull all of those service providers who are probably already in existence, or as we kind of keep going on, they will do a lot of think outside of the box as far as additional community natural supports, and try to make sure that those resources get also connected to the family. So the hope it's wraparound. And the hope really is that it's just a better way to really coordinate the services that sometimes families struggle with, because some of our high intense kids sometimes could have 10 different people involved with their family, and that's pretty overwhelming.
What's a high intense kid?
A high intense, well, there's lots of examples of a high intense kid, but a high intense kid might be someone who's at risk for an out of home placement, or is in need of an out of home placement. And really traditional, just outpatient therapy on a weekly basis just isn't enough. And so it's those kids that just have those needs that go beyond, say, the traditional outpatient approach.
Okay, thanks.
This next question here is, as a state level advocate, governor, legislator, what state policies would help bring more people to the behavioral health workforce?
That's a really good question. What do you think, Scott? I know that always more money is always great, right? I'm sure everybody would nod their head on that. More money. But beyond that.
Yeah, some things I know advocates were working on, and we got a little bit of relief on this, is for licensures of the the degrees and things that you would need for a licensure for being a chemical dependency counselor. I know, so we worked with the board on that, and some of our providers did to help ease some of that. So some of it might be easing the restrictions of how to get a license to be certified by the state.
But do people have to jump through a lot of hoops right now? Is that what's going on?
Yeah, maybe Britton and Lavelle could answer that, since, right, you guys are both treatment individuals who are licensed. So,
well, not to answer that specific question, but to answer the question from the caller. In our perspective, it's a structural imbalance. So we have organizations, like the Adams Board, who cover that care for the uninsured. And as Scott mentioned, and then what we do is we work to get that person on Medicaid so that we bring them into the system so they have insurance. However, the structural imbalance is with the rates.
That's right.
So the Medicaid rates are less than what it costs to deliver the services. So when we talk about Ohio Rise is, one of the things that, Britton talked about, the complex care, but it also has an improved rate structure. And so that's one thing that we believe is going to make Ohio Rise successful. But when we look at Medicaid services across the board, they're underwater. And essentially the amount that an organization or a private practitioner can bill for a service is less than it costs to deliver that service. And so we can't talk about bringing more people to the field if you can't, offer them a wage that is competitive with, other professions. And you can't offer that wage because you can't receive the revenue to pay that wage because of the imbalance in the rate structure. If we compare that rate structure to primary care, and I don't want to throw out any specific numbers because there are a ton of variables here, but we're talking significantly difference in what the rate is to pay for a office visit for primary care versus an office visit for psychotherapy. And so hospitals pop up all the time, beautiful waiting rooms, phenomenal facilities. I was just at one of our regional centers here in Cuyahoga County. There was a waterfall in the lobby. And I was so impressed with that waterfall. And I thought to myself, could we ever afford a waterfall? No, because the rate that they are being paid for me to come in for that office visit more than covers the cost of delivering that visit. It also covers the cost of a waterfall.
Do we happen to know? I'm sorry, do we happen to know how Ohio compares with other states? Because Ohio lawmakers set that rate, right? Is that correct?
There's a federal component to it as well as a state component, but yes, the state of Ohio does set the rate. It is a complex component, but it can be solved, and to the legislator who posed the question, taking a look at those rates, if we could restructure the rates such that they simply cover the cost of delivering service, we could add more people to the field. We could cover that cost. We could pay them a wage that they would get if they were in, a similar field, and more capacity would be in our field. And right now it's sort of stopgap. I mean, it is a situation where we have, phenomenal organizations like the Adams Board, not just our Adams Boards across the state who cover that non-Medicaid, that non-insured person. But once you move them on to Medicaid, and you're trying
Then
to
you're underwater, as you were saying. Yeah. And I know we're almost out of time, but Scott, did you know how we compare in Ohio to other states?
I
mean,
don't know that.
If you don't know
that,
okay.
but Beth texted me. She wanted to remind me that the governor, he just announced his proposal to put $85 million to help the behavioral health workforce. And I really have to say that this administration is very much in favor of the behavioral health community. So for putting $85 million behind it won't really solve it. And I think he even said that too. It won't solve it, but this will be a step, and that some of that money could be used to help pay off student debt and offer paid internships and things like that.
Okay, that'll help. Is there another quick question, Alicia, or should we wrap? Or
there is another question here, is how will the upcoming 988 crisis hotline implementation affect each of your guys' work? I don't know if there's like a short response to that.
I know for Geauga County, our COPE line is part of, I'm not sure I'm going to say this quite right, but is a part of Lifeline. And so therefore 988 will actually go to Geauga County's COPE line. Now, I believe the text messages will go elsewhere. But so, we're just really working pretty hard to make sure that the phone systems are connected. So when a 988 call comes in, it actually gets sent to our county as far as it, and I believe it's set up right now. We set it up as zip codes. And so I don't know what Cuyahoga County is doing. I think it's a work in progress. But the key will be is to try to make sure that the 988 calls go to the right providers.
I think the important part with 988 is that we get the word out to the community, and it becomes just as familiar to everyone as 911. That's really.
Now, have we said what 988 is? Have we said that?
What is behavioral health hotline?
It's a new one, right? It's a new one that's coming online, right?
It's a statewide emergency call number for a mental health crisis.
Yeah.
Okay. And is it operational now, or is it still to come?
No, it's to come in mid-July, I think.
In mid-July, okay.
And I know there's a whole statewide committee working on it, and Cuyahoga County, our 623-688 number will go 988 will go to that number as well. But there's still a lot of things that still have to be worked out that haven't really been worked out yet. So we're all
in the background
to figure this out. Yeah.
Well,
yeah.
It'll be good, but Lavelle, you're saying we got to get the word out.
Right. We need folks, as you mentioned, what is 988, and we need to make sure that people know what it means and they call it when they need it, and call it for someone in crisis as well as call it for themselves.
Okay. Well, I think that might be the last word for this evening. I'd like to thank this panel. I'd like to thank Archie Green, Lavelle Crawford. Lavelle Custer. Did I say Crawford? Sorry about that. I think that's a comedian. Is there a Lavelle Crawford comedian? Scott Osecki and Britton Paul. Thank you all for being here this evening and sharing in this most important conversation. I know there's a lot more work to be done, but you have shared some valuable information with the audience this evening. And I'm going to turn it over to Mr. Napoli for the final word.
Thank you, Marlene. We really appreciate you moderating this evening's discussion. And thank you to the Adams Board for co-sponsoring this important conversation. I want to say a special thank you to our signature sponsor, Rockwell Automation. Their support is greatly appreciaed by all of us. We also want to take the moment to thank IdeaStream Public Media, the Cleveland City Club, WOVU 95.9 FM, WOIO, and WKYC, who live streamed tonight's conversation. And last but certainly not least, we thank our panelists and audience members for joining us on our mission to encourage engagement and dialogue, as well as advance understanding of this very important topic. Our next panel discussion will be held on September 22nd and will focus on voting rights, redistricting, local and national legislation, and the impact on voter turnout. Please join us by registering through our website at unitedwaycleveland.org. Click on our events link and it will take you to the registration page. Registration is complimentary and open to all. Again, thank you for being with us tonight and have a good evening.